Welcome to the deep dive. You know, if you've ever stared at a medical report and just wished you had a secret decoder ring, this deep dive is for you. Today, we are cracking the code on one of the most critical languages in medicine. We're talking about the lexicon radiologists use for mammography reports.
The breast imaging reporting data system, or BI-RADS.
Exactly.
And it really is the essential dictionary for this field. Its power is, it's all in the standardization. The BI-RADS lexicon, the current one, it was 5th edition, it gives this really consistent framework for every single finding.
So it stops one doctor from saying a weird spot on a report.
Precisely.
Yeah.
The goal is to stop that exact thing. It gives them precise universal language so everyone's on the same page.
So it's not just about, a category. It's about reliable communication.
Totally. It's what lets a center in New York compare data accurately with one in Singapore. The American College of Radiology, the ACR, and the Society of Breast Imaging. They're very firm on this.
It's mandatory for training, right?
They recommend mandatory use in all training.
Yeah.
If you're learning breast imaging, you have to use this language. The whole system relies on it for communication and, maybe most importantly, for monitoring patient outcomes over time.
Okay, so let's unpack this for everyone listening. Our mission today is to get past that final BI-RADS score, the category 1 through 6 that everyone knows, and really get into the descriptive language that leads to that score.
The building blocks.
Of building blocks. We want to understand the nuanced terms professionals use. So, where does a report even begin? What are the, mandatory parts?
Okay, so a complete mammography report is a very structured thing. It is not just a free-form summary. It has 3 mandatory components right off the bat.
And the foundation is?
First, you have to state the indication for the examination. Was this a routine screening? Was the patient called back? Is there a palpable lump? That clinical context is everything.
Okay.
Second, you need a succinct description of the overall breast composition. This is absolutely vital.
And that's about breast density, which I know is a big topic. Why is that specific description so critical?
Because breast density, it affects 2 things, both the risk of cancer and just how hard it is to even read the images.
Right.
BI-RADS has 4 categories for it, from A, which is almost entirely fat, to D, which is extremely dense. And if you have dense tissue, C or D, it kind of acts like a smokescreen. You can hide potential tumors.
So it tells the clinician how confident they can even be in the reading.
Exactly. How confident the radiologist can be that they haven't missed something small that's just, hidden in there.
That makes perfect sense. And the third mandatory piece.
That's the clear description of any important findings. And this part has to include a comparison to previous exams, if you have them.
Ah, the comparison.
Yeah, that comparison lets you tell the difference between something new and developing versus something that's been sitting there stable for 5 years.
And stability is almost always a good sign. Okay, so let's talk geography. When you find something, you need to be precise. How do radiologists describe exactly where it is?
They basically use a 4-point GPS system. It's incredibly precise. First, the side, right or left breast. Simple enough. But then you layer on the detail.
Okay.
You have to use quadrant notation and clock face notation.
Both.
Preferably both, yeah, for redundancy.
So something like right breast, upper outer quadrant at 1 o'clock.
Exactly like that. But you're not done. You also have to designate the depth is in the anterior, middle, or posterior third of the breast. And then finally, the distance from the nipple in centimeters.
Wow. That is incredibly precise. Do surgeons really rely on just that text sometimes?
Absolutely. The whole point of those descriptors is to make localization as fast and accurate as possible. It can minimize the time you need for other procedures, like, say, wire localization before surgery. It just saves crucial time.
Okay, let's move to the findings themselves. We'll start with the most structured one, the mass. What actually makes something a mass in BI-RADS language?
Good question. A mass is defined as a 3-dimensional space-occupying lesion. But the key is it has to be seen on 2 different mammographic projections.
2 different views.
Right. If you only see it on one view, we'll usually call it an asymmetry because you can't be sure it's truly 3-dimensional. It could just be overlapping tissue.
So once you confirm it's 3D, the description starts right away with shape.
You mentioned a mnemonic for this.
I did. It's a simple one. ROI. Round, oval, and irregular.
ROI.
Yep. And round and oval, they carry a much higher probability of being benign. Mostly because growth that stays, perfectly contained or elliptical suggests a slower, non-invasive behavior, like a cyst or a simple fibroadenoma.
And irregular is where the needle starts to move toward malignancy.
It does.
But I've heard the margin, the edge of the mass is even more telling. It is. The margin is. It's where you see the battle line. It's the mass interacting with the healthy tissue around it. There are 5 margin descriptors, and for this one, the mnemonic is COMIS, C-O-M-I-S.
Okay, COMIS. So what are the 2 sort of best case scenarios for margins, the ones that point to benign?
The 2 best terms are circumscribed and obscured. Circumscribed means the edges are sharp, they're distinct, well-defined. It looks like it's just pushing tissue out of the way, not invading it.
And obscured.
Obscured just means part of the margin is hidden by normal tissue, but the part you can see looks well-defined and circumscribed.
Okay, so if the mass isn't playing by those rules, we get to the other 3 terms. What are they?
The 3 that raise the probability of malignancy are microlobulated, indistinct, and the one that's the most worrisome, spiculated.
Spiculated. When we say that, what are we actually seeing?
It means we see these tiny radiating spikes spreading out from the mass.
And what are those spikes physiologically? Why is that word so concerning?
Those spikes are the visual proof of the tumor actively invading. It's pulling in the surrounding fibrous tissue. It's not just growing and pushing. It is aggressively infiltrating the structures next to it.
Wow.
And that's why spiculated margins just immediately escalate the concern. They correlate very strongly with malignancy.
That distinction, pushing versus pulling, is such a powerful way to think about it. Okay, moving on from masses. Let's talk about the thing that I think causes the most patient anxiety. Calcifications.
Yes, and these tiny calcium deposits are incredibly common. But the devil is in the details. Their specific shape and distribution are everything. So many are completely harmless.
So give us a few examples of the safe types of calcium.
A great example is popcorn-like calcifications. They're big, classic, benign calcifications, usually larger than 2 to 3 millimeters. We often see them with an involuting fibroadenoma.
Okay, break that down for us. What's an involuting fibroadenoma?
It just means a benign tumor, a fibroadenoma that's basically dying off and hardening. It's calcifying as it shrinks, so it's a sign of a self-limiting benign process.
Got it. What about calcium that's related to, like, blood vessels?
Those are vascular calcifications. They look like parallel tracks or little linear tubes, and you can clearly see they're following the path of a blood vessel. Then you have dystrophic calcifications. They're irregular, bigger than a millimeter, and they often have these lucent centers.
Lucent centers. That sounds odd for a calcification. What does that mean?
It means the calcium has deposited around dead or dying tissue necrosis. So the very center looks sort of translucent. It's a known benign healing response, often after trauma or something.
Okay. And then there's the one with the confusing name, milk of calcium.
Ah, this one's fascinating. It's literally what it sounds like. Calcium that has sedimented inside tiny cysts. So on a standard top-down view, the CC view, they might just look round or kind of smudgy.
Like a fuzzy spot.
Exactly. But then you get a 90-degree lateral view.
Right.
And you've changed the patient's position. So gravity takes over. The calcium settles to the bottom of the cyst and layers out. So on that side view, they look like a crescent shape or a little teacup. And that layering is the definitive proof that it's benign.
That's a classic radiology aha moment. So finally, the term punctate is for the really tiny ones.
Yes. Round calcifications are benign when they're diffuse and small, under a millimeter. But if they're really microscopic, smaller than half a millimeter, the correct term is punctate.
Okay, so we've covered the typically safe ones. Let's pivot to the morphologies that demand immediate attention. This is where the predictive value really jumps.
It does. The 2 highly suspicious types are all about their microscopic look. First, you have fine pleomorphic calcifications. These are irregular, discrete little shapes, and they're tiny, usually less than half a millimeter.
And the risk profile in those?
They carry a positive predictive value for malignancy, a PPV of 29%.
29, so high enough to warrant a biopsy.
Absolutely. That's typically assigned a BI-RADS category 4C, which means moderate concern, and it mandates a biopsy.
Okay. Now, what's the type with the highest risk? The one that sets off all the alarms?
That would be the fine linear or fine linear branching calcifications. They're also thin, irregular, less than half a millimeter. But the key feature is that branching pattern.
Like little tributaries.
Exactly. It suggests irregular filling of a branching duct. And this specific pattern has a huge PPV, 70%.
70? Wow. It's amazing that a microscopic difference in shape, a branching line versus an irregular dot, can jump the risk from 29% to 70%.
It really is. It shows that when cancer starts in a duct and uses that network to spread, the likelihood of it being malignant is just so much higher.
Shifting gears to our 4th category, asymmetries. We know breasts aren't perfectly identical, so how does BI-RADS separate normal variation from something worrisome?
We basically have three types, and it's based on size and change over time. Global asymmetry is a big amount of dense tissue covering at least one whole quadrant compared to the other breast. Focal asymmetry is smaller, more confined, less than a quadrant. You see it on two views, but it doesn't have that convex shapes that would make it a true mass.
And then there's the third one, which is the one that really requires a closer look.
The developing asymmetry, this one is crucial. It's defined as an asymmetry that is new or larger or just more conspicuous than it was on the last exam.
It's the change.
It's the change over time that's scary. About 15% of developing asymmetries are found to be malignant, so they absolutely mandate more evaluation, usually a biopsy.
That 15% rate really forces your hand.
Okay, what about other specific non-mass findings that get their own descriptors?
A really common benign one we see is a normal intramammary lymph node. This will look like a well-circumscribed, maybe slightly lobulated mass, less than a centimeter. The key diagnostic feature is the radiolucent cleft.
And that cleft is basically fat in the center, which tells you it's benign.
Yes, exactly. The fat in the hilum of the node is a very reassuring sign of normal structure, and they're usually in the upper outer quadrant, which is the normal drainage path. Okay, now what about a finding that sounds innocent but actually pushes things towards suspicion?
That would be a solitary dilated duct. It's a rare finding on a mammogram, but it's important because it can be associated with non-calcified ductal carcinoma in situ, or DCIS.
And just to remind our listener, DCIS is?
DCIS is ductal carcinoma in situ. It means you have cancerous cells, but they're still contained inside the duct. They haven't invaded the surrounding tissue yet.
So finding that dilated duct.
It raises the likelihood of malignancy to over 2%, and that's the threshold. That's high enough to suggest suspicious assessment, usually BI-RADS 4A.
Which brings us perfectly to our last section, the actual categorization and management. The BI-RA's 5th edition made a really big structural change here, right? Separating the diagnosis from the action plan.
That's right. It was probably the most significant update, the separation of the BI-RANI assessment category from the actual patient management recommendation. And this was done to give flexibility in specific clinical cases.
So the imaging assessment, the number, is separate from the recommendation. Let's use category 3, likely benign, as an example of how that management is structured.
Okay, so if a finding is BI-RADS 3, which means it has a less than 2% chance of malignancy, the standard recommendation is structured follow-up, usually for 2 years, with imaging every 6 months, and the lesion has to stay stable.
What defines unstable? What triggers a change?
The definition is very tight. If that mass, let's say it's a likely fibroadenoma, if it grows by more than 20% in diameter during that follow-up, the category must be immediately updated to BI-RADS 4.
And a biopsy is recommended.
Now, if the lesion vanishes or becomes clearly benign before the 2 years are up, we can just downgrade it to a BI-RADS 2 or benign.
And just quickly, what about the highest category? What's the rule for BI-RADS 6?
BI-RADS 6 is very specific. It's reserved only for patients who already have a recent biopsy-proven breast cancer diagnosis, but they haven't had their definitive treatment yet. It just confirms that the image you're looking at is, in fact, the known cancer.
Okay, now for the really interesting part. Those cases where the assessment number and the management plan really diverge, this is why they made that split.
Exactly. The classic example is unilateral axillary adenopathy, so swollen lymph nodes in just one armpit without any known infection or reason for it.
Right.
Even if the mammogram of the breast itself looks completely clean, this is highly suspicious. It suggests an occult carcinoma.
Occult as in hidden cancer somewhere else.
Yes, often a primary breast cancer that's just too small to see on the image, or sometimes lymphoma, or a metastasis from another cancer. So because of that high suspicion, the management recommendation has to be aggressive, a workup, a biopsy, so the assessment gets a BI-RADS 4, even though the breast imaging itself is technically clean.
The clinical finding overrides the clean image.
It does.
What's the second example of this discordance? It seems even more nuanced.
This one involves Paget disease of the nipple. A patient might come in with classic clinical symptoms, severe itching, eczema, erosion on the nipple, or areola. These are all clinical signs that are highly suggestive of an underlying malignancy.
But what happens if the mammogram and the ultrasound are totally normal?
This is the key. If the imaging is completely clean, no mass, no suspicious calcifications, no signs of cancer at all, the radiologist must assign a BI-RADS 2 assessment.
Wait a minute. The patient has clinical signs of cancer, but the assessment is BI-RADS 2. Benign. Why?
Because the BI-RADS assessment is purely a statement about the probability of malignancy based on the imaging findings alone. Since the image is normal, the assessment is a 2, but the management recommendation will be immediate clinical evaluation and a skin biopsy because the clinical suspicion is so high.
So the image says benign, but the clinical reality demands urgent action.
Perfect example of the split.
That really drives home the power of this whole lexicon. It forces professionals to be incredibly precise, to categorize every single finding based on known probabilities. And it separates those routine follow-ups from urgent interventions with a real, mathematically defined confidence.
It ensures that every single person who reads that report understands exactly what was found, where it is, and what the known probability is, without any of that subjective, weird spot language.
As we wrap up this deep dive, there's one final detail we should touch on. Mammography is, of course, overwhelmingly associated with women's health, but BI-RADS also has to account for male patients.
That's a really important distinction. The BI-RADS system requires that all mammography exams, regardless of the patient's sex, get a final BI-RADS assessment category. But they don't get a numeric density code like female patients do. The breast composition is just too different.
But the recommendations for what to do next, the management, that often differs, even if the language to describe a finding is the same.
Absolutely. The descriptive lexicon, the commas, margins, the ROI shapes, all of that stays universal. A speculated mass is a speculated mass. But the application changes. For instance, annual screening mammography isn't typically appropriate for men. So it really makes you think about how a universal, standardized lexicon still has to adapt its application to provide tailored care for different patient populations.